Good evening to one and all. Today we'll be discussing about epiretinal membrane, its techniques of removal, its outcomes, and all of it. Before I start the topic proper, let me present to you a case scenario. It's a 56-year-old gentleman who presented with blurred vision in both his eyes of 1 month duration, and his best correct visual acuity in both eyes was 6/6 and 6, and he had immature senile cataract in both eyes. And this is the right eye OCT and left eye OCT. And this is a question to the audience: what do you think should we do next? He complained of metamorphopsia in his right eye, but he told he is fine when with his both eyes open and he can manage.
Left eye also, you see, will continue to change. So she says patient is having a metamorphopsia. Now what you want to do?
He is able to do his daily activities with both the eyes open and with the best corrected visual at 6 senses. So we'd like to wait.
Okay, so fine. So what happened then? Next, what did you do?
So this OCT was done in 2019, and we followed the patient up for 6 years. This is the last visit about 10-20 days back. This is his right eye with a maintained visual acuity of 6/9 and 6, and left eye with a visual acuity of 6/6 and 6, and he still has a component of cataract.
So what does it take home message for this?
Sir, slow progression is there.
Slow progression, one thing, okay.
And
what else?
Relatively vision also has been good, sir. 6/9 only.
Oh,
only
so?
1 letter drop is there.
Okay. Near vision is still N6.
N6. Yeah, vision is also
No
good.
change in complaints. He says just what it was blur. So what else?
We would like to follow up, sir.
No, I'm not asking what you want to do next. What take home message, what you learn from these two OCTs? What you learn?
It's like I shouldn't be very aggressive on like seeing the ERM on the first visit. We should take into consideration the exact complaints and visual acuity and if he's able to manage with the ERM or not. So considering and all these parameters, we have to make a plan, not just seeing the ERM.
So basically generally is slow progressive. Yes, take all these parameters into account. Most important is how symptomatic patient is. Vision is good. Like a OCT may show something different. Also sometimes they can be very deceptive, sometimes can be more, but patient says vision is okay, I'm comfortable, I am able to manage. It just shows even if after 6 years more or less things are not changed. In fact, your ERMS now is fragmented, in fact. So, and vision is more or less maintained over 6 years. Don't rush for a surgery immediately, but yes, you need to follow this patient. Give more importance to symptom than clinical feature. If you like a vision, if it is 6/9, but patient is very, very symptomatic, sometimes difficult for them to manage, yes, you take for surgery. Sometimes it is 6/18, 6/24 vision. Obviously, that can be another indication. But more than vision, what you look at it is how symptomatic patient is because of depending on their jaw profile. Okay, but yes, never rush for this type of eyes. And he's still like 6 after. And of course, today, last week when patient came, we told him he's still maintaining near normal region. Yes, left eye compared to previous, this OCT tug is little bit more, further contraction is there. But patient feel there is no change. So just wait and watch. Okay, so don't rush. Because with current scenario, whatever OCT machines we have, they are so sensitive, practically every patient will have ERM. Okay.
With these insights, we will move into the topic proper.
One more scenario I'll ask, sir. So suppose, sir, same thing, this ERM is there, and now instead of ERM, we have is cataract worsening, and you have 6/18 vision now. The ERM on the OCT looks the same, the fundus looks the same. So would you just advise him to do only cataract surgery? Or would you advise him now, since you're anyway going to cataract surgery, let us also do your ERM removal?
Yeah,
it's a very common question that a lot of people ask.
Good. That's, I think, very pertinent question. So what I do nowadays in this type of cases, I'll ask for PAM. On PAM, if he's improving, I'll give you option, just let us have a cataract surgery alone. And then we look back how much improvement is there, and then take a call. We can take a step approach. Second surgery can be done for ERM removal. but PAP doesn't show improvement, then I'll take him for both cataract plus ERM removal at the same sitting. I hope I answer.
Yes, sir. I mean,
Okay, so today we'll be discussing the indications, techniques, outcomes, and the session is chaired by PB sir. And we'll be going through through as introduction, indications, techniques, and outcome. So, what is it? Epiretinal membrane is a proliferation of retinal glial cells which have gained somehow access to the retinal surface through tiny breaks in the internal limiting membrane. According to the Beaver Dam eye study and the Blue Mountains eye study, the overall prevalence of ERM is thought to be 7 to 11.8%. And the age distribution shows a peak between 70 and 79. The etiological classification, ERM can be grossly classified into idiopathic, which is the most common type, secondary to retinal vascular disease, occlusions, diabetic retinopathy, trauma, intraocular tumors, hematomas, retinitis pigmentosa, and then we have the iatrogenic group. It's also pretty much common, post-operative, even cataract surgery, retinal detachment, silicone oil, extensive laser or cryotherapy. So, idiopathic ERM, what is the pathophysiology? There are three theories which can explain the idiopathic ERM. Most of them revolve around the phenomenon of posterior vitreous detachment. So, when PVD occurs, there can be tiny cracks in the ILM, and through these cracks, microglia gain access to retinal surface and they proliferate over there. And sometimes the hyocytes and the remnant vitreous along the ILM can again proliferate and cause the epiretinal membrane. And PVD can induce ILM avulsion, especially along the blood vessels, and again have an epiretinal proliferation. So this is a pictorial representation. This thing shows most of, although the idiopathic ERM, there is vitreous traction, anomalous PVD, and secondary ERM, it can be secondary to retinal break, uveitis, trauma, where there is a pigment dispersion and inflammatory cells dispersal. So finally, what happens with the cytokines and growth factor, these cells are transformed into myofibroblasts that will secrete the extracellular matrix, and they will result in the contractile ERM. And the retinal traction force is directly proportional to the fold depth. Whenever the traction is more, the retinal fold depth is also increases. So the components of ERM can be extracellular matrix and cells. Extracellular matrix are collagen, laminin, tenacion, fibronectin, and vitronectin. And cells are glial cells, neurites, RP cells, immune cells. And the difference between idiopathic and secondary ERM is in the proportion of these cells. Idiopathic ERMs mostly have glial cells, while the secondary ERMs have the myofibroblast and the RP cells and the altered RP cells, all those cells. And finally, what will happen to the retina with all these things? It will have inner layer damage, which can be in OCT, we can pick it up as ectopic inner foveal layers, thickened nerve fiber layer, intraretinal cystic changes, impaired ERG response. And photoreceptor displacement can also occur. These are all signs in OCT, cotton ball sign, foveolar detachment, and photoreceptor layer microfolds, and Stiles-Crawford effect. Finally, the common pathway leads to impaired visual function, metamorphopsia, and isoconia, and finally decreased visual acuity. Now we'll go to the classifications. A clinical classification for idiopathic ERM. GAS classified ERM into three grades, grade 0, 1, and 2. The grade 0 is the cellophane maculopathy, where you can just see an altered sheen over the macula. Patient is asymptomatic, the vision acuity is maintained. And grade 1 is what we call as crinkled cellophane maculopathy. Here also the patient may or may not have a decreased visual acuity. The patient will have metamorphopsia. And on fundus we can see slight vessel tortuosity. And grade 3 is a macular pucker, where you can see the classic signs of ERM along with decreased visual acuity, and other complications of ERM like cystoid macular edema, traction can be seen. Now moving on to secondary or iatrogenic ERM, they occur secondary to other ocular pathologies or inflammation. Secondary ERM, sometimes you can differentiate them clinically. Secondary ERM, they show more of severe as well as symptomatically. They have more severe metamorphopsia and a myopic refractive error. And they are more eccentrically placed, and they are more dainty looking than idiopathic ERMs. So this is another case scenario. He is a 50-year-old gentleman who underwent a WIT belt buckle, endolaser and silicone oil injection for rheumatogenic retinal detachment, and his vision at GA visit was 6/18 and 18. And the last month, that is 6 months after last visit, that was this month, 6 months after surgery, his vision has dropped to 2/60 and 36. And this is the fundus photo and this is the OCT. You can see a peripapillary ERM causing traction over the posterior pole. And the management we will learn on along the way. So, primary rheumatogenic retinal detachment surgery. What are the risk factors for development of epiretinal membrane? These are the few pointers to keep in mind and will let us know that this patient is more prone for the development of epiretinal membrane. There are more than 3 breaks. That is large breaks. There is more dispersion of retinal pigments. And mostly superior breaks. And associated choroidal detachment, macula off status, PVR changes, prior pneumatic retinopathy, intraoperative cryotherapy, laser burns, especially more than 1,000 shots, duration of surgery, and use of silicone oil. All these things have shown it will result in a more chance for epiretinal membrane formation. And the PVD status and ERM after a scleral buckle. So in the first diagram, if you see closely, there is a break and the buckle is there. But if there is a detached vitreous, the dispersed RP cells can gain access to the macula and there is a more prolific ERM formation. But if it's a formed vitreous, the RP cells migrate slowly and there is less ERM formation. So how will you work up these patients? You have to take a proper history, including the visual acuity, the duration of symptoms, whether the patient has metamorphopsia, all those things. And then we have to do a thorough clinical evaluation, including Amsler charting. And what are the investigations we can do? We can do an OCT. Now OCT has become a primary tool in diagnosis and prognostication of ERM. OCTA can also be used, multimodal imaging, fluorescent angiography, multifocal ERG, microperimetry, all these can be used. This is a multimodal imaging. You can see this is somewhat like a grade 1 ERM, and in multimodal imaging it is picked up more clearly. And what about OCT in ERM? So in OCT, as you all know, ERM will be seen as a discrete, irregular, hyperreflective line above the inner retinal surface. It can be accompanied by wrinkling of the inner retinal layers with hyperreflective spaces. And what do you mean by ectopic inner foveal layers? This is a feature seen in higher grades of ERM. They are continuous hyperreflective band extending from the inner nuclear layer and inner plexiform layer, which crosses the foveal region. It is seen in the advanced stages of ERM. Goveto et al. Introduced an SD-OCT based classification for ERM. In this, if you see, the first picture is the stage 1 ERM. Here, the ERM is beginning to form. The foveal pit is still visible. And you can see all the retinal layers are all well defined. Then moving on to stage 2. Here, there is a flat foveal profile. There is absence of foveal pit. And still the retinal layers are preserved. And in stage 3, here the retinal layers are still defined but not as well defined as stage 2, and you can see the beginning of ectopic inner foveal layers. And stage 4, there is disruption of the retinal layers and presence of the ectopic inner foveal layers. You can see the corresponding fundus images also. And OCTA, now OCTA has also become indispensable in the management of macular disorders. Here you can see this is a stage 1. This is stage 1. This is this is a fellow eye. This is a fellow eye, and this is the eye with the ERM. In stage 1, we can see the vessels are not that affected. In stage 2, it is slowly encroaching onto the fovea, and there is a displacement of the vessels towards the fovea. And finally, in the stage 3, there is the entire foveal center. There is a traction and vessel tortuosity. And FFA in ERM, we no longer use FFA in the diagnosis of ERM, but previously it has been used, and FFA can still be used as an important prognostication factor. Based on the FFA, ERM can be classified into various grades. Depending on the vascular leakage, it can be classified from grade 1 to 4, from where the vascular leakage is, whether it is in central 1 mm or outside it. And based on the vascular distortion also, it can be graded from grade 0 to 4. So the thing is that leakage in the last picture, as you can see, there is leakage in and around the fovea. This is a very bad prognostic sign. So we have learned about the basic things. Now, when to intervene? When the patient presents to you with reduced visual acuity, less than 20/60. And another scenario is when the patient has vision is better than 20/60, but the patient has a very troubling metamorphopsia. And the patient requires professionally better visual acuity. In these 3 cases, we can consider surgical intervention. Before moving on to surgery, we have to do a thorough preoperative assessment, including a detailed peripheral fundus examination. We cannot afford to miss a secondary ERM due to a peripheral RD. So you have to rule out other peripheral breaks and identify the underlying cause of secondary ERM. That is, if a ERM is associated with uveitis, you should also manage uveitis and not just the ERM. And you can rule out a pseudo hole. Pseudo hole is an ERM which is without a macular involvement. And here mostly the vision will not be affected. And rule out certain other differential diagnoses like congenital hypertrophy of the retina and the retinal pigment, a congenital hematoma of the retina and the retinal pigment epithelium. And you should always keep in mind the lens status and whether the cataract is there. What are the few DDs? One is as I told, congenital hypertrophy, hematoma of the retina and the retinal pigment epithelium, and the lamellar hole associated epiretinal membrane. Here, in the case management of CHRRPE, there are 2 schools of thought. There is, you can either manage it initially before the ERM has become very prominent. And the problem with the ERM in CHRPE is that it is the glial tissue is interwoven into the inner retinal layers. So whenever you peel the ERM, you are going to damage retina. So finally the vision will be poor. And as well as this lamellar hole, here also the vision will be mostly preserved. You don't have to intervene. Mostly this patient will have a good vision. So what to do? Mostly we have to do a vitrectomy, ERM removal, plus or minus ILM peeling. McKimmer used a 23 gauge bent needle. He was the first to remove an ERM after a 17 gauge pars plana vitrectomy. And the aim of the surgery is to remove the membrane and relieve all the traction. So we have to do a 3-port pars plana vitrectomy. We can either use contact or non-contact visualization system, whichever is comfortable. Each one has their own advantages and disadvantages. Visualization adjuvants like vital dyes can be used. Instruments, depending upon the surgeon's discretion and comfort, as well as the type of the ERM, the toughness of the ERM, different instruments can be used. And there are various removal techniques. So pars plana vitrectomy, to do a vitrectomy or not. There is one school of thought that without doing vitrectomy, you can just go in and remove the ERM and come back. But the problem with that is that the patient will have troubling floaters and all those things. So most of the surgeons do a complete vitrectomy with PVD induction. And how visualization, you can either use contact or non-contact viewing. Moving on to vital dyes. Vital dyes are a very important part of the macular surgery. We have a lot of vital dyes. The commonly used one is the indocyanin green. It stains the ILM. And the ERM is less stained, but the problem with the safety concern, it is highly toxic to the RPE, and especially if used with macular hole, it's seen to affect the RPE, and it's found to stay in the eye for a long time. Next comes the trypan blue. It is the one thing which will stain the ERM, and the toxicity profile is also good. Then we have our IVTA. It is mainly for staining the vitreous, but it can also be used to stain the ERM. If it does the IVTA all over the posterior pole, we can visualize the ERM also. Then we have the brilliant blue G. It will stain your ILM, but not much of the ERM. And we have the modifications of brilliant blue G. There is the membrane blue dual. It's a combination of trypan blue as well as BBG in this glucose. It will stain ILM, ERM as well as PVR membrane. What do you mean by negative staining? In this picture you can see, so here this is a eye stained by the brilliant blue dye. Here you can see ILM is stained, and this area it doesn't take up stain. So there is something blocking the blue from reaching the ILM. So that is your epiretinal membrane. And how to peel? There are various techniques. If you can see a definite edge, you can use an outside in technique, that is drag and snag. If the edge is not seen, we can use an inside out technique. You can pinch and peel the membrane. You can even use a soft tip extrusion cannula or viscosaline dissection. And how to create an edge. I will be detailing about all these instruments later when I show the videos. These are the few instruments you can use. You can use an MVR blade, pick, an end gripping forceps, diamond dusted scraper, finesse loop or a bent needle. So this is a basic surgical procedure. After a complete vitrectomy and the PVD induction, we find the edge of the membrane. We try to pull it with the forceps. And once the membrane is off, we check the ILM. If there are many defects in the ILM, we can proceed to remove the ILM as well. The drag and snag technique. Here, the MVR blade can be used to develop the edge, and mostly around the thickest part or the most refractile part. I will explain this with the help of a video. So, this is a 20 gauge system. Here you can see the surgeon is using a pick, and slowly from the outside in, surgeon is trying to remove the membrane slowly.
That was getting age basically.
And once you get the edge of the membrane, you can use a forceps to lift it up. So now a well-defined edge is obtained. So you introduce the forceps and hold it lightly, try to pull it up and leave it, and again keep on pulling and looking at the surrounding retina that you are not causing excessive tug or traction. And this is a video in which you can see the IVT is used to stain the ERM. You have to make sure that IVT is not clumped. It's like a dusting of the IVT. Here the surgeon is using an MVR blade to slowly create an edge. And once the edge is created, you slowly lift it off. And then you can use the forceps to move in a circumferential fashion and peel off the entire membrane. If you accidentally peel the nerve fiber layer, you can see hemorrhages and retinal whitening also. Next technique is the pinch and peel technique. It's supposed to be a better technique than the drag and snag, because in this you are not engaging the retina. It is usually more important if you can't see the clear edge of the membrane. And if you accidentally peel the nerve fiber layer, you can see retinal whitening and hemorrhages. So this is a video in which you can see you go in with the forceps closed. You reach the retinal surface, you create a dimple. No, you go in with your forceps open, create a dimple, and you close the forceps and move to and forth, back and forth to create an edge or a break in the membrane. You can look how long the membrane is, how extensive the membrane is, and move further so that the entire membrane is peeled. You have to make sure that you leave the membrane and then you re-grasp it at the base. Don't try to pull it off in a single go. Look, carefully observe the surrounding retina for excessive traction. The one thing to remember is that ERM will be more extensive than is what is visible to our eyes. Yes. And this is a video in which you can use a finesse loop to identify. Whenever it's a very thin membrane, you can't find an edge, you can use this retractable finesse loop to create an edge. So once the edge is created, you can use the forceps to lift off the edge. And this is using the MVR blade. Here also you can see slowly you create an edge and peel off with the forceps. Looking at the changing the vectoral force accordingly so that you don't create more excessive tug. Constantly re-grasping more towards the base of the membrane. This is again a 20 gauge vitrectomy system. Here a retractable pick has been used and an edge is created at the most tough or the prominent part of the ERM. And then you again use the forceps and gently peel it away. This is another video which showing the the iatrogenic ERM removal. So first an MVR blade is used to create a small nick in the posterior hyaloid face. And now the surgeon is introducing scissors closed and introducing through the gap, and he is trying to induce the PVD.
Why you have labeled it iatrogenic? It's secondary, no?
It
Secondary
is
ERM.
Post-surgery.
Yeah, it's secondary to this post.
She liked the word iatrogenic. I said leave it. I say secondary. She says okay because we created with our surgical. I said it's not exactly we created on the table, but it's okay. She is happy with that. Okay. She want to take a responsibility for that.
Sir,
Very silicon was पहले वाला था.
this looks like there was hardly any surgery before. Looks more like a buccal, post-buccal, where you can see the thickening of the hyaloid and the full PVD is there.
Yes, PVD is there.
Yeah, as if they have induced the PVD now.
Yes.
So it's just the thickening of the posterior hyaloid, so thick that it has covered the whole. So it's very common scenario after buccal surgeries.
Yes. Okay. So you can see with now the surgeon has used a chandelier illumination and the membrane is stabilized with the forceps, and using a pick, a plane was created and slowly the membrane is peeled off in toto.
If I can interrupt here, can you hear me?
Yeah, ma'am.
Yes.
I think Chetan, this is my surgery.
I know, ma'am.
And this is not, I think, post-surgery. I think this is the patient who you have also seen.
Yeah, ma'am.
And you have advised surgery because this membrane was very densely adherent to the macula.
Yeah, ma'am.
So I don't think it is post-surgery.
No, I was saying that this kind of membranes we get even in like post-buccal also we can get this like thick ERM with no PVD, and then ultimately we have to induce the PVD.
Yes, but the post-surgery membranes which are there on the macula, they are not that densely adherent unless there is some scar surrounding that.
Yeah, ma'am.
But otherwise they are easily removed. This this seems to be widely densely attached to the macula underlying.
Yeah, coming back to your point, ma'am, that is what I was going to say. The pinch and think technique is usually for the secondary membranes that you see.
Yes,
They are
sir.
not densely adherent to the retina unlike the idiopathic membranes, where we don't know where all are the additions of the ERM to the retina, where you will definitely not want to try pull directly at the thing. We will always look for an edge, and then we slowly enlarge the edge, elevate the edge, and then thing. The second membrane that you see, that SOR, post
Yes, sir.
SOR or post everything, those membrane, yes, like pinch and then you pull it off, because you know that it's not that densely adherent to the underlying retinal surface. So you'll have less chance of making a macular hole because of that.
Yes. Okay. This is another idiopathic ERM removal. Here also the MVR blade is used to create an edge. Make sure your cornea is always moist. Once you create an edge, you can change over to forceps and try to peel it off. Yes. So what are there is a option of intraoperative OCT. Intraoperative OCT can be used to ensure the completeness of ERM removal. And there is a study called Discover in which they divided the population into the study subjects into two groups. One group was a conventional surgery with a mandatory ILM peeling. The other thing in which we used an intraoperative OCT. But finally, they did not find any significant difference in the visual outcomes or recurrence rate. So, whether to do a primary ILM peeling or not. The ILM peeling is found to reduce the rate of postoperative ERM. But we have to weigh it against the potential harmful effects of ILM peeling, because ILM peeling is associated with nerve fiber layer damage. And the recurrence rate also with ILM peeling is much less. So what are the points against and for ILM peeling? Why to peel an ILM? It ensures more complete removal of the ERM. It avoids recurrences. And this ILM can act as a scaffold for the proliferative cells. But why not to peel an ILM? It doesn't lead to better best-corrected visual acuity, and it can cause damage to the Muller cell foot plate, and it significantly slows down the visual recovery. And what are the effects of ILM peeling? You can see the swelling of the arcuate nerve fiber layer, the dissociated nerve fiber layer, that is Dauphinal, which is seen as the inner retinal layer dimpling on the unfast image. Then you can even create a paracentral macular hole, and there can be reduced retinal sensitivity and microscotoma evident on the microperimetry, and reduced B wave amplitude on ERG, and there can be even nasal displacement of the fovea. This is a postoperative image. 6 days post ILM peeling, you can see the swelling of the nerve fiber layer, and 3 months post peeling, you can see there is dissociated nerve fiber layer. What are the complications of this surgery? Intraoperatively, as in any surgery, you can have bleeding, peripheral or posterior breaks, lens touch. And postoperatively, cataract formation, retinal detachment, recurrences, and endophthalmitis. What is the outcome of ERM removal surgery? Visual improvement of 2 or more lines is seen in 60 to 85% of cases, 6 to 12 months after surgery, with 44 to 55% achieving a visual acuity of 20/50 or better. What are the prognostic factors? The preoperative prognostic factors include a visual acuity. So bad prognostic signs include a visual acuity of less than 20/200, symptoms lasting more than 6 months, the grade of the ERM. The farther the grade is, worse will the prognosis, and if it is associated with the outer retinal changes, or it is associated with a CME. You can see these are the few signs in OCT. This is the cone outer segment tip defect and a cotton ball sign. These are all changes seen in the OCT which can tell us that this patient, the visual recovery will be much less. Ellipsoids on disruption and leakage on FFA. And intraoperative factors being an iatrogenic extrafoveal macular break. I have to stress the point that visual recovery is a very slow process taking about 6 months to 1 year. Now we will see two cases. Case 1, she is a 56-year-old lady who presented to us with a vision of 618 and 6. And this was her OCT at presentation. And we offered her vitrectomy, ILM peeling and ERM removal. And at her GA visit, it was 615 and 6. And 1 year later, you can see it improved to 612 and 6. And 4.5 years later, she has a visual acuity of 7.5 and 6 with a maintained foveal contour. And in the other eye, you can see slowly the ERM is developing and the contour has become shallow. And this is another case. This is an ERM with a VMT. So this gentleman presented to us with a visual acuity of 7.5 and 6. And since the vision was good, an option of observation was given. And she presented 9 months later with a drop in vision to 618 and 6 with cystoid spaces and increased traction. And we gave him the option of surgery. And in the immediate post-op period, you can see there is relief of traction. And at the GA visit, his vision was 6.9 and 6 with some inflammatory macular edema. He was managed with the topical NSAIDs, and 2.5 months after surgery, he still have a 6.9 and 6 vision with a resolution of the macular edema. And to conclude, the precision is important, careful tissue handling is important, and thorough understanding of retinal anatomy, and a proper pre-op counseling of the patient because it needs a prolonged recovery time is important. Finally, do no harm. Thank you to PB sir for giving me all the videos as well as DAD madam. Actually, I didn't know it was your video. Thank you.